My name is Elizabeth Leone, and I'm the chairperson of the New York City Local Early Intervention Coordinating Council. And I'd like to welcome you all to our web-based LEICC meeting. As of May 15th, 2014, New York City's local law number 103 of 2013 and the New York State Open Meetings Law require open meetings to be both webcast and archived. This meeting is being recorded today. I will now review the procedures for the LEICC meetings. For in-person LEICC meetings, attendees should pre-register on the New York City Department of Health Early Intervention LEICC webpage. For the web-based LEICC meetings, attendees will find a link on the New York City Department of Health Early Intervention LEICC webpage. Meetings are open to the public, but the audience does not address the LEICC members during the meeting. For this web-based meeting, we will not be using the chat or the Q&A features. For this web-based LEICC meeting, members of the public were asked to submit written public comment by emailing. Public comments will be read into the record at the end of the meeting. LEICC members will raise their hands instead of raising their cards to make comments. LEICC members should keep their cameras on during the meeting. And transcription is available for this meeting. Written meeting minutes will also be made available. LEICC members, would you please introduce yourselves?
So Trisha DeVito, please introduce yourself.
Good morning. My name is Trisha DeVito. I'm with the New York City Department of Education, Special Education Office.
Patricia Gray.
Good morning, everyone. My name is Pat Gray, and I am part of the LEICC meeting and the academic partners through Hunter School of Social Work at the Silberman.
Simone Hawkins.
Good morning. My name is Simone Hawkins. I'm the Assistant Commissioner for the Bureau of Child Care at the New York City Department of Health and Mental Hygiene.
Thank you. Mary McCord.
Hi, my name is Mary McCord, and I'm the Director of Pediatrics at Gotham Health, part of New York City Health and Hospitals, and I'm trying to get my video to work. We'll see if I can do it.
Okay. Elizabeth Leone.
Hi, my name is Elizabeth Leone. I'm the chairperson of the LEICC. Good to meet you. Hi.
Yuri Pollock.
Good morning. My name is Yuri Pollock, and I'm an Associate Commissioner at the New York City Administration for Children's Services. Good to see everyone.
Thank you. Roseanne Saltzman.
Hi, good morning. I'm Roseanne Saltzman. I'm the Program Director at Up We Grow.
Thank you. Sonu Sangowi.
Good morning, everyone. I'm Sonu Sangoi. I'm the Clinical Director at Achieve Beyond. Good to see you all.
Thank you. And Jessica Wallinstein.
Hi, Jessica Wallinstein, New York City Department of Education, Division of Early Childhood Ed.
Okay, thank you. And that's it because Kara hasn't joined yet.
Okay, thank you, Aracelis.
You're welcome.
So now, we will now approve the minutes for the LEICC meeting. Will someone make a motion to approve the minutes?
I motion to approve the minutes.
Thank you. And will someone second the motion?
Second.
I second that motion.
Thank you. Now, Aracelis is going to read the names of the members to approve the LEICC minutes. The LEICC members should say if they approve, oppose, or will abstain from approving the minutes.
Lydia, do you approve the minutes?
I approve the minutes.
Elizabeth Leone, do you approve?
Approved.
Trisha DeVito.
Approve.
Patricia Gray.
Approved.
Simone Hawkins.
Approve.
Mary McCord.
Approved.
Yuri Pollock,
Yes, I approve.
Roseanne Saltzman,
Approved.
Sonu Sangohi,
Yes, I approve.
and Jessica Wallenstein.
Approved.
Thank you. That is it.
Thank you, Aracelis. So now we're going to move on to the next agenda item. We will have Lydia Ledniak, Assistant Commissioner, have our SEICC report and the EI program updates.
Thank you, Liz. Welcome everyone to the fall LEICC minutes. I was hoping that it could be in person, but we're not there quite yet, though I am hopeful for the spring. So today I'm going to start by talking about the September 15th, 2021 State Early Intervention Coordinating Council meeting. So as you can see, they had a rather extensive agenda for the meeting. I will be highlighting a couple of key points that I think are very relevant and timely for the local Early Intervention Coordinating Council. We're going to talk about Bureau administrative updates, the Provider Workforce Capacity Task Force, the Rate Setting Methodology Task Force, Early Intervention Race and Ethnicity Data Report, and the EI Hub. So in terms of SEICC administrative updates, the state reiterated that all current COVID-19 guidance remains in place, with teletherapy continuing to be an available service option, and that updated SDOH Bureau of Early Intervention guidance is currently in the approval process. In terms of the covered lives update, you can see the bill numbers there for your reference and anybody who cares to look them up. But these bills, which is basically creating a covered lives pool to help infuse additional funding into the early intervention program, was passed by the New York State Senate and Assembly this year, but the bill has not yet been delivered to the governor for signature. However, we still do have until the end of the year to hopefully see that happen. So, you know, just making sure that everybody is aware of that. The early intervention program regulations are currently in their final phase of preparation prior to being published in the register. Of course, once they're published in the register, we will do a thorough analysis here to ensure that everybody understands the full impact of the language of the proposed changes. Next, the SEICC provided an update on the Provider Workforce Capacity Task Force. The task force goal is to develop recommendations for the department to increase provider workforce capacity to deliver early intervention services. The SEICC then revised the charge of this task force to include a telehealth subgroup as part of this committee. So as a result of the work of this committee, the SEICC voted to adopt key competencies for the delivery of evidence-based evaluations and services in the New York State Early Intervention Program. We have talked about them before, and they are very much based on what is basically the standard of care within the literature for this age group across disciplines. And with the recommendation to adopt those competencies, there was a related recommendation to reduce the 1,600-hour requirement by 1/3 to 1,000 hours in New York State regulations in order to improve and increase workforce capacity. This committee also began development of a companion document in partnership with our subgroup, our academic partner subgroup, and local academic partners elsewhere to support the implementation of these competencies. This group finalized the telehealth surveys, and they were submitted to the State Department of Health for statewide dissemination. It is broadly expected that the results of this survey will be used to draft telehealth guidance for the state, if telehealth is going to be made a permanently available service option in the early intervention system. The last quarter, the SCICC initiated a rate setting methodology task force. I'm happy to say that New York City will be sitting on that task force. The charge of the task force is to develop recommendations to the State Department of Health regarding the current rate methodology. The task force will base its recommendations on the analysis of data regarding socioeconomic status, region, race, ethnicity, access to services, and impact on agencies and staff of the early intervention program. The objective will be to ensure that rates are equitable, efficient, and cost-effective. The primary topics, or the first topics that this group will be looking at, will be rates for service delivery, methods to address capacity in underserved areas, including telehealth, analysis on how to ensure equity by reviewing data on poverty, regions, and race ethnicity to determine the equity and access issues and how those impact the methodology, to review how the rates are devised to help inform discussions and research on if rates should be adjusted and how they should be adjusted, either the methodology or the rates themselves. And then review how rates impact workforce staff at all levels, which is very good because we focus a lot on things like, you know, what should be the rate for group services, what should be the rate for, you know, therapeutic interventions, but this sort of envisions being able to focus on other portions of rates, such as service coordination rates, say. The state early intervention program, the state also is releasing data on race ethnicity, which is the first time for the State Department of Health and early intervention. So we're obviously very happy about that because we've been advocating for it and you know, supporting similar work to happen at the state level as we've been initiating in New York City. So this data, which will be released as a report on the state's website, will include the following elements broken down by race ethnicity: age at referral, percentage of children evaluated, percentage of children found eligible, percentage of children with services, timeliness of service initiation, and timeliness of initial IFSP. The report will be posted on the state's website, and the state expects to engage local programs and agencies to identify and address barriers to equitable access to services. The state also provided an update on the EI Hub implementation. Just to refresh everybody's memory, this is the case management system that is supposed to replace the New York Early Intervention System, which is the current case management system that everybody in the state uses. At this point, there is an expected implementation date of spring 2022. NICE will move into a read-only status 2 weeks prior to the EI Hub go-live date. And then NICE will be retired 2 to 3 months after being moved to read-only status. Upcoming events that everybody should take note of are internal and external testing of components for both municipal users as well as providers. External feedback sessions with providers and municipal users. Migration testing, because a certain amount of NICE data for active children will have to move into the new system, right? So that we're not using 2 systems in parallel. There will be internal and external end-to-end testing. And there are currently plans underway for a fall stakeholder readiness survey, which I encourage everybody to complete. to ensure that the state, as well as Public Consulting Group, the entity who's implementing the EI Hub, is fully aware of the concerns and the potential impact that a spring 2022 implementation date will have. I am going to pause there to see if there are any questions about the SCICC report. Don't see any hands, so I think I'm going to move on to early intervention program updates. Specifically, I'm going to be covering 3 areas: the annual Federal Office of Special Education Programs monitoring and some issues that we are seeing within that area. We're going to be talking about COVID-19 updates, and I'm going to be talking about where we are with our regional office operations. So for background, each year, the Federal Office of Special Education Programs rates each state's early intervention program. So, and that then is carried down to each municipality. So state and municipal scores are based on compliance with regulatory timelines, which is 50% of our score. And then second is ratings of child progress on the Child Outcomes Survey. So the first item, compliance with regulatory timelines, is measured via the quote, annual performance review or APR process. And here, service coordination providers are asked to confirm reasons for delays in IFSP meetings, services, and transition in a January to March time period of the year. And we just completed this exercise for 2021. This year, there were a good amount of challenges with this process. Both new and legacy providers have challenges that they expressed to us. Responders also raised concerns about the frequency of late billing and the failure to collect SC notes, right? So if you don't have SC notes, you don't know why things were late. So in order to address these challenges that we as a system encountered this year, next year, we are going to modify our processes. We are going to identify and work with APR agency contacts earlier in the year. We are going to provide a webinar to explain and do active Q&A sessions about how to complete the APR. And we are going to work more closely with providers to really help them understand reasons for delay. The second part of our annual compliance score is measured against the Child Outcomes Study, which we call COS, which basically asks parents and therapists to rate children's development at entry and exit in the early intervention program. This is a manual process. Exit forms are collected by service coordinators at every annual IFSP meeting and at the exit from the early intervention program. The ongoing challenge, and I don't think that this is a challenge just for this year, but it is an ongoing challenge that we've been grappling with over the last several years, is that exit forms are just not being consistently completed. And so we are planning to implement some upcoming improvements where we are going to be doing ongoing follow-up with service coordinators, providers, and EIODs to obtain exit forms, and we're going to be more aggressive about that. So I'm going to shift into talking about our response to COVID-19. And this is, information that you've seen before, though it's displayed in a new and exciting way. But, I will sort of fill in some new information as we go. So in March 2020, we were deemed an essential service during New York State on pause. March 24th, all early intervention services in New York City were delivered using teletherapy exclusively. On June 22nd, 2020, we released the Return to In-Person Services Action Plan. And then on July 6th, in-person home community-based services, individual facility-based services, and evaluation services shifted back to mixed method approach where they could be delivered either using telehealth or in person. In September, we released our COVID reporting requirements for providers. And since we have implemented our COVID reporting requirements, we, in partnership with the provider community, have been able to intervene on 320 confirmed cases happening all over, homes, with providers, with children, everywhere, to ensure that we acted swiftly to either to change the location of services or to pause services where appropriate, to meet the child and family's needs. On October 21st, 2020, groups reopened with multiple transportation options being available, with some restrictions continuing to be in place on transportation to ensure that transportation on buses is safe. On January 14th, 2021, all EI therapists and teachers became eligible for the COVID-19 vaccine. And on June 23rd, 2021, New York State announced that all executive orders related to COVID-19 were ending. But the State Department of Health quickly followed up, indicating that all current early intervention COVID-19 guidance remained in effect until new guidance was issued. So that is where we are right now. The most recent development that impacts early intervention is the child care order. So as you know, earlier this month, New York City Department of Health issued a child care order, which requires every child care program contracted with the Department of Education to exclude from the premises any staff person who has not provided proof of vaccination against COVID-19. Staff person, the definition of staff person includes a specialist providing support services, therapy, special education, or other services at the covered child care program to an individual child pursuant to a mandate. Okay, so what this means is that early intervention therapists and teachers who are going to be going on site to deliver early intervention services in DOE contracted child care programs will be required to show proof of vaccination against COVID-19. What this order is not is a vaccine mandate for EI. And I want to be clear about that. We've gotten questions about that, but at this point in time, EI is not covered. However, the New York City Department of Health strongly encourages all New Yorkers to be vaccinated. Okay. Regional office operations. We, along with the rest of the city workforce, are returning to work in person 5 days a week. Our borough offices are not yet currently open to the public, and IFSP meetings continue to be facilitated remotely. And we are continuing to operate following all current COVID-19 guidelines. And, at this point, we are starting to consider what's going to happen next. So in terms of, what may or may not happen on site. So please sort of stay tuned and we will share information with you as soon as it is made available, because I know changes in operations at the Bureau necessitate in many times changes in operations at provider agencies as well. So we will make sure that we are communicating that clearly and diligently. Are there any questions about anything that I have reported to you on today? Okay, great. Oh, and I see that Dr. Periasomni has joined us. Welcome. Thank you for joining us today.
Thank you. Thank you so much. And as I put in the chat, I'm covering the inpatient floor, and I apologize if I have to leave early. Thank you for.
No problem. We understand how busy you are. Thank you for joining. Okay, Liz?
All right, thank you, Lydia. So now we will have Jeanette Gong, Director of Intervention Quality Initiatives. And Jeanette will be presenting on the ACS initiative and the Service Coordination Professional Development Institute update.
Next slide. So good morning, everyone. Today I'll provide a brief report on where we are on the BEI ACS foster care focus groups. The multidisciplinary evaluations are important in determining eligibility for the early intervention program and in providing information about children's development and the eligibility for the early intervention program. Completing evaluations for children in foster care involves additional procedural steps for service coordinators and evaluators. In order to support this population, in 2018, New York City Early Intervention and ACS developed a data exchange and monthly data reports to share information with ACS and foster care agencies on the status of each child in the EI program. Early intervention professionals that work with children and families in ACS continue to report that communication gaps and delays in EI evaluations still occur. Next slide, please. So to better understand and to address the drivers of these delays, BEI and ACS are holding focus groups with ACS caseworkers, educational specialists, and their supervisors, foster care parents, and parents of children in foster care. This information is important, and what we learn from the focus groups may impact the revisions to the New York City Early Intervention Surrogacy Chapter and training on surrogacy and parental rights for EI providers. Next slide, please. So where are we in the steps to the focus groups? Since the last LEICC meeting, we have identified and contracted with a focus group consultant. We've drafted the screening and facilitator guides. Specifically, the screening guides provide the criteria and questions used for the recruitment of focus group participants, and the facilitator guides provide background information and the questions that the consultant may use during the focus groups. We also submitted all the guides to be reviewed by the New York City LEICC, Advocates for Children, Brooklyn Defenders, and Legal Aid. Thank you to everyone for taking the time to review and provide feedback on these documents. It's really important. Currently, we are waiting for feedback from ACS on the edits and comments, and then we will finalize these guides. In addition, BEI and ACS will then schedule and hold a kickoff meeting with the consultants to review the focus groups and the guides and to address any of their questions. Next slide, please. So all focus group participants will receive gift cards. Each focus group session will be about 90 minutes long. The consultant is expected to recruit about 20 people for each group, and the consultant will recruit parents, foster parents, and ACS workers that had children referred to the early intervention program from January 2018 to February 2020, prior to the COVID-19 pandemic. All focus groups will be held remotely. Next slide, please. The goal of the focus group is to find out the drivers of delay for foster care children in the evaluation process and retention of foster care children in early intervention. Therefore, the focus group questions fall into these general categories: referral, surrogacy, retention, other challenges in the EI process, and recommendations. The consultant will summarize this information gathered from the three groups and the results will then be shared with the LEICC, and the information will be used to inform current and future initiatives to improve timeliness and EI participation. Next slide. Are there any questions?
I think what I'd like to add here to Jeanette's very clear presentation is that we're also moving forward on sharing the revisions to the surrogacy chapter with the LEICC and other stakeholders, because we know that there has been historical feedback on this process, and so we want to start incorporating those needed modifications. And then once the focus groups are done, we're going to see if there's anything else that needs to be enhanced within the chapter before finalization. So I just wanted to make sure that everybody understood the connection between those two pieces, because they're really integral, and we want to make sure that the surrogacy chapter reflects sort of the lived experience of people actually interacting with our systems. So does anybody have any questions or comments about this project? Okay, and I see that Kara has joined us. Welcome, Kara. Thank you for joining.
Apologies for being late. And I will chime in and just say thank you all for undertaking this project. It's incredibly important to the children in foster care that you all serve. And I'm excited to see what the results of the focus groups are, and to also help with the surrogacy chapter. So thank you for taking this up.
Yes, we need your help, because you have to, let us know when we're being too ambitious or not ambitious enough. So, that's really why we've kind of tried to be expansive in the folks that we've asked to look at this, because we're over here, we're not interacting with the families in the way that providers are every day, and so it's really important. Okay. Anyone else on that point before Jeanette moves on to her next topic? No. Okay, Jeanette.
Okay.
Do it.
Okay, next slide, please. So in May and June 2021, the BEI Hunter College Service Coordination Professional Development Institute, that's a mouthful, so we all lovingly call it the SCPDI, successfully held 6 remote trainings with participants that represented about 55 EI provider agencies. The presenters were Jackie Chasen, Patricia Gray, Jonica Koji, and Tonya Spence. The goal of SCPDI is to support service coordinators' engagement and retention of EI families with a focus on trauma-informed care, family-centered practices, implicit bias, and reflective practices. Next slide, please. For the fall 2021 series, the SCPDI will perform the same 6 one-day trainings. The remote trainings are being offered during the work week in the months of October and November 2021. The trainings include reading materials, videos, handouts, tools, group discussions, and activities. And I have to say, in the spring 2021 trainings, these group discussions were very rich and exciting. These are not recorded to preserve the confidentiality of the discussions during the trainings. Next slide, please. So for participants to receive a certificate for each training with or without CEUs or CTLEs, they're expected to complete these 5 components: a pre-test prior to each training, verify their attendance at the beginning and at the end of each training. Active participation is expected of everyone. Complete the post-test and the training evaluation survey for each training. And finally, complete 1 post-SCPDI training survey 6 weeks after their last training. That's an attempt by us to try to see if people are instituting new methods or new information after their training. So we want to check in with everybody. So, next slide, please. There were 6 dates for the fall 2021 series. Based on the feedback we received in the spring, many asked that the series occur during the work week. So we tried to schedule it from Monday to Thursday. Actually, based on the schedule of the presenters, 5 are on a Tuesday and 1 falls on a Monday. An email to providers went out on September 16th. So I suggest that people try to register as soon as possible if they're interested in taking any of these courses. Next slide, please. To enhance regional office participation, at least one regional director will rotate at each SCPDI training. The regional director's goals are 1, to promote collaboration, 2, to connect with the provider community, and 3, to answer questions. Next slide, please. Lastly, if anyone has questions related to the SCPDI trainings, BEI has a new dedicated email address, scpdi@health.nyc.gov. Does anyone have any questions?
Jeanette, how many people are currently registered?
There are about, I think, 70 to 80 registered for each session. But that doesn't mean that everyone will show up on the day of the training.
Yeah, what we're seeing with remote trainings is that there's a higher no-show rate than in person, which is interesting. I guess because it doesn't take much to kind of say you'll do it and then not attend. So we are over registering for, overbooking these sessions so that we have about 30 or 40 participants per training, which is what we think is an optimal
Yes.
group size.
Yes. And also for discussions. It makes for nice group discussions when you have a manageable number of people at the training. Patricia, do you want to add anything?
No, I think you covered a lot. It was great. The staff from BEI, Diana and Solange, they are just phenomenal. So it's really been helpful.
Agreed.
Great.
Agreed.
Thank you.
Okay. I guess there's no questions.
Okay, thank you, Jeanette. And I have to say that I'm so happy that these trainings have been going well. From what Patricia had presented last time, I see that, it was really an exciting time and getting all that information. And I love the fact that the family and the parents are being, put in the forefront and making people understand that this is family-based and we need to remember the family.
Absolutely.
And how we do incorporate that. So thank you so much from a parent's point of view. Okay, so now we're going to continue with Nora Puffett, Director of Administration and Data Management. And Nora will be presenting the data report and provider oversight activities.
And
good morning. So the data report. So this first slide is just a different way of looking at the same data we've really been opening with ever since the pandemic. We always think about 2019 as our baseline year. And what we're doing is contrasting our return to that baseline. What you see here is 2020 on the left, 2021 on the right for those lines, the blue to purple lines. The yellow shading behind them for both of them represents 2019. So what you can see is both in looking at the line, how we've been changing over time since January 2020, and how that compares to our baseline of 2019. And this makes it very clear about the significant drop and then the, steady climb that happened in 2020. And what you see is that now we're hitting a point in 2021 where we are really starting to, have to really get into it with some of these initiatives that you're hearing about. We are having the same kind of fluctuations we have always, but they're a little bit more extreme. And at this point, it's hard to say where we will end up with a total number in the end, but we'll talk about that on the next slide. So this is number of referrals, and I just want to flag here that we're shifting from calendar year to fiscal year. And we always report on fiscal year to be consistent with data we report elsewhere, so you can always make sense of it. But reminder that fiscal year is from July to June. So when we talk about fiscal year 20, the whole second half of that was January to June 2020 and was all about the pandemic, and yet the first year was nothing about the pandemic. So it's an unusual year. So you see, though, once again, comparing to our baseline of 2019, 2020 went down. It went down about 17%. It was a big drop, and that's in total. And then the following year, we have really started our rebound, as you saw, but we're still lower than 2019. It was about a 9% lower than 2019 at that point. So we've kind of gone halfway. So at this point, it's just too soon to say about 2022. We've only got 2 months of data. If we tried to project from what we've got there, knowing that July and August are low, I would expect us to at least be exceeding last year. But we don't know yet. It's too soon to say if we'll make it back to 2019 levels. The other thing I want to mention up front here, because it applies in all of the slides that follow, and you've seen this till now, the absolute numbers changed. The distribution did not. Whether we're looking at borough or racial group, that distribution did not change. And I think one possible way to think about that is some of the major drivers of referral are well child visits and childcare. And across the board, no one was doing them. So some of our biggest drivers are almost universal to early childhood. And that may be why the distribution is so consistent. Next slide. So this is the referrals by race and ethnicity, and you see what I mean. It's the same data, and it's the same distribution really since 2018. Next slide, please. Now this is services, and I want to remind everybody, services are downstream of referrals. So whatever happens with referrals, the impact on services is going to be a little bit delayed. And so that's why you see what might seem surprising, which was it was a really minor drop in 2020. And actually the drop continued in 2021, which is very different from referrals, but it reflects what happened the previous year with referrals. And so that's really our focus right there now is really about addressing referrals, which in turn addresses services. Next slide, please. And again, services by race and ethnicity, and again, incredibly consistent. Next slide, please. And then this is children with any type of service, basically children we touch in any way. And you see a combined effect of referrals and services so that 2020 wasn't as bad, but 2021 is actually a little bit lower. And again, distribution, just the same. Next slide, please. And again, race and ethnicity, data looks exactly the same in terms of distribution. Next slide, please. So this is our waterfall, and just a reminder about what this is trying to talk about. This takes individual referred children and says, what happens to them in EI? How far in the process do they go? And our number one concern is always referred to evaluated because everyone should get there. Then there's eligible, and then there's services. And we know that not every child will be eligible. But we look at those 4 stages, and we really focus our initiatives very much around what are we doing to get children through that process. And again, what you can see is there may have been a little bit more of a group impact here than in the earlier slides, maybe 3% for Latinx and Asian children, but very, very small. Next slide. And then final slide that I know is completely changing gears, but we got to do it, which is about the question of children with insurance. Children getting services, do we know if they have insurance? The Medicaid population, very consistent, 63, 65%, that's historically completely consistent, but we know that 9% of children do not have any insurance, but they continue to not have insurance recorded, and that continues to be one of the many things we work on with service coordination providers. And that is the data report. So any questions? Nope, okay. And then just a quick jump to provider oversight. I'm sure many people thought that, what can you do about provider oversight in a pandemic? But there's a lot you can do. So first I want to remind everyone what we told you previously, which is during that period of March and April, we took all of our auditors off of audits and they called 9,000 families, more than 9,000, to ask them, how is it going? Has your service coordinator been in touch? Has your therapist talked to you about, teletherapy and all of that? So we really, just redirected that whole group of people to do what we thought was the most important thing right then. But this past spring, we said we'd really like to get back to annual monitoring because we're very proud of the fact that every year we monitor every agency. And so we decided we're going to do that again, but we're going to do it remotely. And when you're doing it remotely, you have to do it a little bit differently. What we do is we request the files, providers send them in electronically. It's just a much slower process. So we decided to limit ourselves in some ways, and we said, what is most important during a pandemic? And the answer to us was ongoing service coordination and service provision. Those are the things that are going to hold on to you and get you what you came here for and need during a pandemic. And so those are the two things that we chose to look at, and we were looking at them for 2020. So we were looking during the pandemic to see how providers did. That said, we understand that providers had a lot of challenges at that time, and so we did not do scoring in reports. We are sending back letters of advisement, noting where the weaknesses were, when they were consistent from previous years that we've seen with this provider, and recommendations about best practice and resources. And we have gotten about a third done, another third in progress, and we will get to the final third before the end of the year. Overall, the compliance actually looks very similar to previous years. And then the final thing I want to note is that we also, throughout the last year and a half, have been doing a lot of ad hoc session note reviews and progress note reviews. We've reached most providers with those, and that was our chance to give feedback on, are your notes compliant, and, also other factors that we could comment on because it wasn't a rating, it was just, our feedback. So that's where provider oversight is. Does anyone have any questions about that? Okay, thank you.
Thank you, Nora. Okay, so now we will have Catherine Canary, our medical director, and Catherine McVeigh, our director of research and analysis, and they will be presenting on the COVID-19 vaccine update and the grant to improve referral and bidirectional communication in healthcare.
Hi, good morning, everyone. Next slide. So let's start with some good news. As you know, for several months now, all New Yorkers 12 and older are eligible for vaccine using the Pfizer vaccine. And as of today, more than 11 million doses have been given to New York City residents. This data on the slide is actually a little bit out of date by about a week. So as of this morning, 63% of all New Yorkers, which is more than 5 million New York City residents, are fully vaccinated, and 70% of all New York City residents have received at least one dose. Next slide. So one objection that we sometimes hear to getting a COVID-19 vaccine is, well, I've had COVID, so I'm already immune. I don't need to be vaccinated. But even if you've had a COVID-19 infection, you should still be vaccinated for two reasons. One is that vaccination strengthens and appears to extend the immunity that's conferred by natural infection. And the second reason is that a study at another state in the union, and I think it came from Kentucky, that showed that if you've had COVID and you're not vaccinated, you're twice as likely to be reinfected as someone who's had a prior COVID infection and is vaccinated. So the bottom line is, please get vaccinated. Next slide. So a question that is asked by people who have been vaccinated is, what's the story with booster doses? So a booster is just another dose of a vaccine that's given to someone who's built enough protection after vaccination, but then that protection decreased over time, or this is also called waning immunity. And a common example you may know of personally would be like tetanus boosters that you're supposed to get every 10 years. So COVID-19 vaccines are working very well to prevent severe illness, hospitalization, and death, even against the Delta variant. But it appears that with the Delta, we're starting to see reduced protection against mild and moderate disease. So this is the reason behind booster shots, so that vaccinated people can maintain their protection over the coming months. So by contrast to boosters, the additional dose that's given to people who are immunocompromised is called a third dose. And this helps them build more protection against the disease because they either didn't build enough or may not have built any protection from their first dose. Next slide. So as of last week, the FDA amended the emergency use authorization for Pfizer to allow for boosters at least 6 months after completing the first series for certain populations. And let me just move to the next slide, because let's be specific about which ones are recommended by the CDC. Next slide, please. So a few days after the FDA issued their amendment, the CDC made recommendations for boosters for specific groups of adults. So this is more than just stating that boosters are available. They're actually saying these groups should get a vaccine and these may get a vaccine. So the shoulds include adults 65 and older, residents in long-term care settings, and adults who are 50 to 64 and have underlying medical conditions. So these folks should get a Pfizer booster dose. Other groups may get a booster, and these include adults 18 to 49 with underlying medical conditions, and any adult 18 to 64 who's at increased risk for COVID exposure and transmission, either because of their occupation, like being a school teacher, or institutional setting. So these are the folks who may get a booster. Next slide, please. So at the time of the CDC recommendations last Friday, Dr. Wallinstein, the CDC director, stated that recommendations for Moderna and Johnson & Johnson boosters would be addressed as soon as the data for these vaccines is available. And like for the Pfizer booster, once the data is available, the FDA will review it, issue their authorization, and then the ACIP will make recommendations. Next slide. So boosters are only available with Pfizer as of this moment, but by contrast, third doses can be given to severely immunocompromised people using either of the two mRNA vaccines, Moderna or Pfizer, depending on which vaccine a person received for their primary series. Next slide, please. So as we've said a couple of times during this presentation, we just want to stress again the importance of getting vaccinated and, taking advantage of all of the precautions, including, particularly if you're not vaccinated, you need to wear a mask to cover your nose and mouth, use social distancing, avoid crowds in indoor spaces with poor ventilation, and practice good hand hygiene. Of course, that's a good idea for anybody all the time, whether it's COVID or not. Okay, next slide. So we're happy to announce that we're building on a successful model used in other parts of our department, including the Bureau of Child Care. So our thanks to Simone. The New York City Department of Health is sponsoring a community conversation around COVID-19 vaccines for our EI providers. And this is going to take place in 3 days on Monday evening from 6 to 7 p.m. via Zoom. A flyer went out advertising this conversation last week. and the Zoom link was included in the flyer. So we're hoping you can join us, and please bring your questions. Any questions about COVID, vaccines, boosters, I can try to answer? Okay, so let's just move on. I'm going to talk now about this, something that you've heard about the last couple of LEICC meetings, and that is the pilot that EI and 3 health and hospital sites have initiated to facilitate referrals to the program by using the electronic health record at those health and hospital sites, and to improve retention in the program by encouraging parental consent to share information between EI and the healthcare provider. So as you know, we're particularly interested in achieving improved outcomes in referral and retention, especially in communities that have referral and retention rates that are lower than the citywide average. Next slide, please. So today we're really happy to announce that we're building on this important work that was started in partnership with Health and Hospitals under the leadership of Dr. McCord. So thank you, Dr. McCord. BEI has received a grant from the Robin Hood Foundation, which is being administered through the Fund for Public Health in New York. And this grant will expand on the pilot by involving all of the primary care sites at health and hospitals, as well as 3 other partner healthcare facilities across the city. We're also planning to evaluate the effectiveness of this model so that we can encourage it to be replicated elsewhere. Next slide. So we'll be collaborating, as I said, with partner sites all across the city, including some sites through Montefiore, NYU Langone in Sunset Park, One Brooklyn Health, and as I said, all of the pediatric primary care practices. And I'll let Dr. McVeigh take it from the next slide.
Thank you, Kathy, and good morning, everyone. As you're well aware and was recently reinforced by Nora's presentation, BEI is a data-driven program. And so, of course, with this new initiative, data monitoring and evaluation are in the forefront of our minds. So you can expect to see that we will be developing summary reports similar to those that Nora has presented for the cohort of hospitals that are part of this project, and other similar kinds of reports. But additionally, the bidirectional data exchange is a critical component to this initiative. It's not enough to simply electronically fax through the EHR the referrals. One of the critical features that we really want to know about with this project is how can we not only increase the referrals, but the retention as well. And so we're hoping that this bidirectional data exchange will really facilitate that. So what does that mean? It means that on a monthly basis, the participating sites will send us a roster of those families that have consented to have us share information about their EI referral process back to the referring provider. And then we'll create a database of those people, and each month we will filter the names of those children who have been referred in the past 3 months and send a report back to the referring site that sends some, a variety of information back, but critically sends back the status of the referral, where it is in process, and the action step for the sites. So for example, we do our match between the list and our referral database, and there's no evidence that the referral ever came in. Then the status is referral not found, or some words along those lines, and the action step is resubmit referral. Next situation, the referral has come in, the child was evaluated on time, so the report action step or status would be evaluation completed with the date, and the action step is no action required. And so we're in the process of developing a rather complex algorithm for each possible permutation of where a referral could be in process and coming up with the language and coding for the status and the action step. So that's what's happening at the sort of child level data exchange. But then we also want to evaluate the impact of this initiative overall. And for that, we're using a difference in differences approach. So if you look at the figure on the right, you'll see the bottom line represents, hypothetically, the referral rate for children who were not seen by the sites that are participating in the project. So hypothetically, their FY19 referral rate was around 10%, and between FY19 and FY23, hypothetically, it increases to 11%. And then you'll see the blue line is the FY19 hypothetical referral rate for the participating sites, and then going up to the FY23 level. And so in order to do this evaluation of the impact, we need to essentially subtract out the growth that would have happened anyways. And so the dotted purple line is what we call the counterfactual, and that would be the estimated growth in the participating sites if we hadn't done anything. And then the difference between the blue line and the purple line in FY23 is the impact. And there's both simple statistical ways to do this and complex ones. We hopefully will be able to do both to fully understand what the impact is and whether it is statistically significant, but also meaningful. And so we'll probably be trying to do the simple version to compare FY21 to FY19 for the 3 H&H sites, and then keep going, building out both the simple and complex versions going forward. Thank you.
Any questions for Tina or Kathy about the project? Just want to say a big thank you to Mary for being such a champion for this work. I don't think we would have been able to, one, I know we would not have been able to do this H&H work without her, but I think that, you know, the early success at H&H really helped us to expand this project.
Likewise, I would say without the cooperation of the team on your side, like we've really worked through problems at a nitty-gritty level and met on a regular basis. Some people meet almost weekly, and the big group meets monthly, and we've been doing that for more than a year. So that I think we're equally impressed and thankful for the level of collaboration that we've managed to have. It's a slow process, but it's getting better every time we meet.
Okay. Thank you, Tina.
Okay, so now we will hear from Sherlo Mclean, Acting Director of Outreach and Staff Development. And Sherlo will be presenting on the community outreach.
Good morning, everyone. Happy Friday. I'll be covering the outreach activities we have done so far this year. Next slide. So one of our goals is to increase the number of EI referrals and retention of families, particularly Black and Latinx, to pre-pandemic levels. Next slide. In order for us to accomplish this, we continue to target 40 zip codes that are considered to be low referring. And these are the areas that we are concentrating our outreach efforts. So in the Bronx, we are looking at Northeast Bronx, Highbridge, Morrisania, Pelham, and Throgsneck. In Brooklyn, it's Bedford-Stuyvesant, Crown Heights, and Brownsville. East Flatbush, Canarsie, Flatlands, East New York, and Williamsburg, Bushwick. We're also in Manhattan, Central Harlem, Morningside, East Harlem, in Queens, Southeast Queens, Jamaica, the Rockaways, and Southwest Queens, and in Staten Island, Fort Richmond, Stapleton, St. George. Next slide. So responding to the COVID pandemic, we shifted the way we reach our community partners and families. And to inform the community providers that EI was still open, we emailed flyers to an existing public health platform that allow us to track communications that were opened and forwarded. This year, we sent a mass communication about the virtual presentation to 218 providers, which was forwarded to over 700 individuals. To reach our parents with the parent presentations, we use text to families to send broadcasts of presentation dates to families just referred. We send out an average of 5 texts monthly to newly referred families within 6 weeks of referral who do not know if their child is eligible yet. It averages about 1,500 families per broadcast and has a click rate of 40 to 60 clicks per broadcast. The next part of our community engagement is virtual presentations. Since we were all remote, we needed to develop another way to deliver presentations. So we launched 2 virtual presentations, one for parents and one for providers. Our provider presentation emphasized referring and integrating EI process within the organization's intake and/or orientation. For this calendar year, we presented to 48 organizations, reaching 113 community providers, and have conducted weekends and weekday parent presentation, reaching 119 parents for a total of 232 individuals reached through virtual presentations. We also provide ongoing training to new nurse-family partnership and newborn home visiting staff, ACS PAMs, and Queens Library staff as part of their orientation. For healthcare, we continue to work with our community partners, such as faith-based, WIC, medical community outreach, daycares, through outdoor health fairs and virtual events, reaching 785 individuals. This year, we also sit on community partnership meetings, and we sit on meetings such as with Health First, Emblem Health, Jamaica Community Partnership, Sheltering Arms, East Flatbush Community Partnership, Queens Child Care in New York, and United for Brownsville. We collaborate with Aileen Gonzalez, reaching approximately 135 individuals. This gives us an opportunity to utilize our grassroots partners to network, disseminate EI information, and distribute flyers on our parent and provider presentations. Within the last 2 months, we have been testing a different approach to entrench ourselves by community detailing in neighborhoods and distributing information, as well as placing our EI posters or flyers in visible areas at various businesses where there's heavy foot traffic. These locations are corner stores, delis, laundromats, salons, daycare, supermarkets, and some neighborhood pediatric offices. We have connected with 26 businesses so far and have placed flyers in 13 businesses in visible areas. Using this approach, we have been able to distribute our EI brochures to over 109 individuals. Last year, for childcare, we called over 1,088 family daycare providers, which we sent 300 providers to Public Health Action Kit. These action kits include family education materials such as the Early Help Matter brochure, developmental monitoring brochures, information on family rights in EI, and assistive technology, and 6 new EI videos. We have brochures available in 10 languages. This year, we followed up with those daycares to determine its usage, and we were able to contact 122 who are using the kits to inform parents about the early intervention program. And lastly, this unit worked along with our medical director to outreach to pediatrician, nurses, and social workers, and we have reached 300 hospital staff. Next slide. So this is basically just a snapshot of what we've been doing for our activities and in the Outreach and Staff Development Unit. If you have any questions, I'll gladly take them.
Thank you, Sherla. And I just want to say thank you publicly to you and your team, and a lot of our Bureau staff volunteer and do this work on the weekends, at night, in addition to their regular activities, because we're so dedicated to this work. And I think that it's really been the work of this unit and all of the community partnerships that you've been able to form, that's really helped get us back
Thank
to
you.
where we need to be and increasing and improving our referral rate. We obviously need to do more of it, but I think we are on a track that is moving upward, and I think that has a lot to do with how we've been able to mobilize our community networks. So Sherla is here, and we are always interested in new partnerships and in new collaborations.
Thank you so much.
Okay, thank you.
Okay.
Thank you.
Thank you, Sherla. So now we'll have Mary Elizabeth Bashan, our evaluation specialist, and she will be presenting on the telehealth survey results.
Thank you, and good morning, everyone. As you may already know, the Bureau of Early Intervention developed and conducted 3 surveys to obtain feedback from families, interventionists, and agency administrators about their experience with teletherapy. 3 separate surveys containing quantitative and qualitative items were administered using the SurveyMonkey platform from January 10th to February 7th, 2021. I am working on summarizing the results of each survey. Today I'm presenting select results from the agency survey. Next slide. The agency survey included 10 open-ended and 11 quantitative or close-ended questions. The results I will share include a sample of 57 agency respondents. Let me briefly describe the sample. 70% of respondents indicated that their agency served 100 to more than 500 families in 2019. Almost all respondents reported that their agency provides individual therapy in home and community settings. 14 respondents said that their agency provides individual services in home and community settings, facility-based settings, and also group services. 42 respondents were from agencies that provide initial and ongoing service coordination, and 22 respondents indicated that their agencies provide service in all 5 boroughs. Overall, 90% or 51 agency respondents reported that they want to continue offering teletherapy as a regular component of the EI service mix after the COVID-19 public health emergency. Next slide. The transition to teletherapy happened very quickly, and understandably, most agencies experienced some challenges with the transition. 38.6% of agency respondents described their transition as challenging or extremely challenging. Among these, some of the most frequently reported challenges were getting the consents and session logs signed by families, getting families to agree to teletherapy services, interventionists quickly learning best practices in the delivery of teletherapy, and engaging parents or guardians in teletherapy sessions. Next slide. Agencies adapted quickly to the teletherapy context. Some examples of how agencies modified or added practices include creating a best practices training session for interventionists and the benefits of telehealth training for families. They studied New York State and New York City guidance and met virtually to discuss. They increased communication with families, calling and sending surveys to find out how teletherapy services were going. They created a WhatsApp group among interventionists to share ideas. They expanded quality assurance procedures to include review of service logs, COVID statements on session notes, and built a tracking system to monitor receipt of consents for teletherapy services. Next slide. When asked about the benefits of teletherapy, the most frequently mentioned benefit was greater parent involvement in sessions and carryover of therapeutic techniques. This is what one respondent wrote. The format of teletherapy has, by its nature, forced what has always been the goal of the early intervention program: parent involvement and the provider coaching the parent in strategies with the child. The next most frequently reported benefit was the ability to cover cases in difficult to serve areas. Another respondent wrote, teletherapy enables us to cover cases in difficult to serve areas, and it enables therapists to expand their coverage area and caseload. 86% of agency respondents reported that interventionists were more willing to accept cases from hard to service neighborhoods. Next slide. When asked about concerns related to continuing teletherapy beyond the pandemic, agency respondents mentioned the paperwork burden, concern that some parents or guardians will decide that they don't have time for teletherapy due to the level of involvement required, concern that some parents and interventionists believe that in-person services are the best and only way to deliver early intervention to young children, technology limitations, particularly in families led by less tech-savvy caregivers, concern that teletherapy will become the primary option in underserved areas, and that interventionists may not want to return to in-person services. Next slide. Finally, we asked for recommendations for supporting continued implementation of teletherapy. Agency respondents had these recommendations: provide more training, use videos, share success stories, have agencies that were successful mentor other agencies, increase communication to parents and guardians about teletherapy, explain the benefits and the expectation for parent involvement at initiation of services, make resources that help teletherapy work well accessible to all families, continue free internet for lower income families, create a process for families to obtain toys, books, and other materials to aid teletherapy sessions. Thank you for your time and attention to my presentation. I look forward to sharing the results of the family and the interventionist surveys at upcoming LEICC meetings.
Are there any questions for or comments for Mary on the presentation? It's not. Well, thank you so much. I think it's a, you know, we started with this one. I think the parent presentation and the therapist presentation will also be informative, and I think it's gonna what we've seen overall is that people have very different perspectives, and so the parent concerns are not necessarily those of the agencies and the therapists. So it's going to be interesting, you know, once all of those results are ready.
Okay. So now we will hear from Jessica Wallinstein, Senior Director of Children with Disabilities Birth to 5, Division of Early Childhood Education at the New York City Department of Education. She will be presenting on the New York City Department of Education Early Childhood Updates.
Good morning. Can you hear me? Okay, great. Sorry, I was having some tech issues. Hope everyone is doing well. I'm excited to be able to share some information today on the enhancement contract that the Department of Ed is planning for state-approved preschool special education program providers, also known as 4410s. We are going to be opening this opportunity to to the 4410 community, but we think it would be great for the EI community to get this information, since we know you're often working with the same families, with families who may be entering the preschool system. So we want to make sure you are fully aware of the DOE's plans here. But know that what I am talking about today is really a preschool opportunity, and I'll provide some more details. Okay. So what we are doing with this initiative, which is an initiative that is one of the suite of 6 initiatives that were funded around preschool special education in the city executive budget, which I think I presented on at the last LEICC. So we're so thrilled that the city is making a real investment in preschool special ed. And this one initiative is intended to bring 4410s as well as 4201s, state-supported schools, into the 3K and pre-K for all portfolio that the New York City Department of Education currently runs. And by doing this, we hope to stabilize the sector of 4410 and 4201 programs by giving them financial resources that will enable them to recruit and retain teachers. We've been hearing from the field for a while about how that is such a challenge, particularly in light of the pay parity deal that was made for other contracted providers that are part of 3K and pre-K. We also see this as our mechanism for enabling programs to add needed special class seats in areas of the city where we continue to see a deficit, even with enrollments being down during the pandemic. And we see this as a way over time to promote access to services in the least restrictive environment. So that's the overview. I'm going to give you a few more details, but I also have to give a disclaimer that we are still in the planning phase. We are still in the budget development phase. So everything I share today is, draft, subject to revision by our various city partners and state and federal entities. Okay, next slide. I also want to be clear about some information that I'm not able to share today. So we don't yet have detailed information on what the funding for the salary increases will be. That will require a number of conversations internally and externally before we are able to come out with something publicly. Similarly, we don't have specific funding amounts for programs, and we are still working out our exact release dates. Okay, next slide. Okay, so some basics. Who's eligible? All operating 4410 and 4201 providers are eligible to respond, and even providers who are seeking state approval and anticipate getting it within the current school year are also welcome to respond. This is an enhancement contract, so it has no impact on programs' current base contracts. It will be provided in addition to and provide additional funding. In order to apply, we're going to be releasing a solicitation. It's not going to be an RFP, so it doesn't have quite as lengthy of a process, but we are going through a procurement process where we release a solicitation, likely in the late fall. It'll be open for a set amount of time. Providers will be able to respond, and then our goal is to make this opportunity available broadly. So there'll be a minimum threshold, and any program that meets that threshold will be eligible. And that's because we view this as our opportunity to really change the sector and bring all programs into 3K and pre-K, which means bring all children with disabilities into a set of supports that we already provide to general education students. And we want to make sure that students with disabilities and with the most severe disabilities also have access to them. Okay, next slide. So I keep saying becoming part of the DOE 3K and pre-K for all program. So what does that actually mean? This means that for programs that respond to the solicitation and are awarded, they would be held to the same quality expectations as well as receive the same supports to meet those expectations as the rest of the Division of Early Childhood's 3K and pre-K portfolio. It also means I also want to just note very clearly that we know that 4410s already have to meet many requirements from the state, and know that the requirements that we have in place we view as complementary, and we're working closely with the state to make sure that nothing that we are doing is conflicting or overly burdensome. One of the frameworks that we use to guide the work of our programs is the Early Childhood Framework for Quality, and we are encouraging providers to become familiar with this. It is our vision for high quality care and early education. It's meant to be a guide that enables us to talk to different programs with a common language, but know that it is not a set of compliance-driven regulations. It is aspirational. There's nothing punitive when a program is not meeting a part of it. It is meant to be a tool that we use to support all programs. We also expect programs to meet the tenets in our Birth to 5 policy handbook. And again, this is meant to be a supportive resource. The handbook calls together regulations that we know programs are already accountable to. So for example, it speaks in plain language about Article 47 and IDEA requirements, and again, is meant to be a resource and not at all the source of something punitive. Okay, next slide. I'm going to talk a little bit more about some of the program supports that stems from the DOE's Division of Early Childhood. So we provide on-site supports, including access to social workers who provide mental health consultation, instructional coordinators who support in implementing and adapting curriculum, policy support specialists who help programs meet health and safety requirements from DOHMH, for example, and operation analysts who support with budgets and program operations. We also offer a number of multiple professional learning opportunities. Some of these are already open to 4410s and 4201s, but this would bring about a more comprehensive set of PL, as well as an opportunity to join PL with providers in other sectors, including those who are already in 3K and pre-K. We provide access to a number of instructional resources, including our curriculum and authentic assessment systems, and we provide feedback via the class and ECHRS assessment system. Okay, next slide. So just to pull out the key program requirements that will be different for programs who receive this enhancement contract, we do provide a minimum of 6-hour and 20-minute day for students. This does include meal, snack, and nap. So we do find that this is close to what a lot of 4410s are providing already, but yes, it is more. We also require that programs participate in the Child and Adult Care Food Program, which is basically funding to provide meals. You can also seek a waiver if this is something that's really not appropriate given the circumstances of your program. We also require that programs use a curriculum that we provide or submit a waiver. We certainly do not want to disrupt successful practice that's already happening, which is why we have these waiver processes. Programs must use an authentic assessment tool, which can be supportive of quarterly progress reports that are provided to parents. And then, of course, developmental screening for general education students that are in SCIS classes, and then monthly attendance reporting. And I know that some of these bring with them some additional financial burden, and part of this enhancement contract will provide funding for the additional costs that come with these. And I'm going to talk a little bit about that in a couple minutes. Next slide. So section planning. As I mentioned before, one of the key goals of this enhancement contract is to enable programs to be able to expand and meet the special class need, as well as add integrated programs as we move towards our goal of serving more students in less restrictive environments, and we have a need for more of those seats. In some parts of the city, we're not there yet. But for special classes in particular, I'm going to talk through how we hope to support programs to expand. So one thing that we are doing is we're working with our Office of Teacher Quality and Recruitment to think about ways that we can build workforce capacity for certified teachers who have the preschool and special ed license. We're also looking to provide funding for the higher salaries. We will also provide some startup funding for programs that are opening new classes. We also are going to build in a mechanism for awarding general ed seats if you are expanding SCIS. And then we're going to be providing we'll be taking on some of the risk that you might be concerned about when thinking about expansion and low enrollment. So in our budget development process, we will be accounting for that risk that you're taking on. And then we will also continue our work with the state to ensure that state approvals are moving as quickly as possible for all programs that are part of this opportunity. Okay, next slide. So this is a summary of the major funding categories that we currently envision. And again, we are still in the planning phase, but first and foremost, we see this as our pathway to providing higher salaries for the sector. And then there's going to be a number of costs that are associated with extending to the 6-hour and 20-minute day, including prorated costs for staff salaries, potentially subs to cover prep periods, as well as facility costs. As I mentioned before, startup funding. We also plan to fund required background checks for staff. And we're excited to provide some flexible funds that can be used to promote LRE and inclusion in your program. So that could be for professional learning, untiered instruction, or sensory equipment, things like that, as well as other ideas that I'm sure programs will be able to propose. Okay. So this last slide just goes over the basic timeline and process. We are looking to release the solicitation before the end of this season. It'll be open for responses. We'll make awards in the winter, and then contracts will start on the first day of the fiscal year, July 1. So that's where we are right now, and I'm happy to open it up and take any questions.
Thank you, Jessica, for this presentation and for all of this work in in moving this forward and moving this through the process. Does anybody have any questions for Jessica on any of this? Okay, thank you.
Thank you, Jessica. And now we will have committee reports. Does the Academic Preparation and Professional Development Subcommittee have anything to report? I think that's a no.
No, I don't think there are any committee reports.
Yeah, I don't see it.
Yes.
Okay. Does the Service Coordination Subcommittee have anything to report? No? Okay.
No.
All right. So now we will have public comments. Were there any comments submitted?
No, there are no public comments.
No public comment. Okay. So we have no public comments to report. And so now I would like to adjourn the meeting. Thank you so much, everyone, for joining us today. Be well and be safe. And thank you for coming.
Thank
Have
you.
a good day, everyone.
You hope everyone has a great weekend.
Thank you.
Thank you. You too.
Thank you.